Good morning, folks. John Adamson, the Rehab and Documentation Guru. Just saw an interesting patient. Guy had a heart attack, and he has a history that includes things like diabetes and old back injury and whatnot. And after the surgery, after the hospitalization because of the heart attack, which included getting some stents, he ended up with getting some necrosis on his right lower extremity. And they did do stents in both femoral arteries, which increased the blood flow to his right lower extremity, but not completely. And on clinical examination, he had some necrosis on his first and second toes at the distal ends. And what was interesting was, I mean, you could really feel the demarcation of good blood flow to not good. His foot was had rubor, so that chronic redness is often a sign of chronic ischemia. And if you went from the ankle where it was warm and moved your hand just gradually towards his toes, it got progressively cooler. And the doctors are hoping they can save his foot. And I don't see why he would have his whole foot amputated, but it's clear he's going to need to have something done. What's interesting about him, and this lets you know further that it's a vascular issue, is one of his chief complaints is pain in his foot. But not when he's up and about. Like when he's up and about and walking, it feels good. And usually you think of claudication pain, especially in muscles, as involving activity. Like you walk for a little bit and then you get calf pain, and that's claudication pain. But this guy actually feels good when he's up and about or he has his feet dangling. But as soon as he puts his feet up level in bed, pain starts coming on. He gets burning. He gets tingling sensation in his feet. And that's clearly a sign that he's getting a lack of arterial blood flow to the feet. And so anyway, will he heal out this area of necrosis? Like, will he get healthy tissue growing up underneath it? And I don't think so. My concern would be for him regarding under treatment of this area, and being that he's a diabetic, he does have stable caps of the necrosis. So when you see necrosis, you always look to see if there's any separation between the necrotic tissue and the healthy tissue. That would be an area where you'd be concerned about infection getting in. But he's got no such mark of separation, so it's continuous, and so that's tissue you want to leave alone for the time being until it starts separating, because otherwise you could actually promote infection. And anyway, so he's got what appears to be healthy tissue adjoining the necrosis. So I think they're hoping it will just, naturally slough off without any problems to him. But guy that's got to be carefully watched, carefully monitored. And again, I was impressed by the fact that patients are way undereducated. Like he's got diabetes, and he was telling me, did this happen because of me? Like, was I born with this condition? And I said, no, you've got diabetes. You've had it for a while. Diabetes causes problems with blood flow, especially to, places further away from your heart. And that was the first time he'd heard that. Why should I be the first one to tell him that? A doctor at some point should have mentioned that to him. But patients are way undereducated about their conditions. Anyway, just brief case scenario. Just something to keep in mind as you're looking at your patients with peripheral vascular disease. Hope you're having a great day. Take care and God bless.